Thank you, Professor Gupta. Good evening to be amongst you this evening. And I must say that we have heard about this holmium laser enucleation of prostate. Virtually we are hearing about for last 15 years or even more. And the main thing which has always been highlighted is the learning curve of this procedure. And when we talk about this learning curve, I initially at the outset, I thank the organizers of UCCon and the Luminous India to have given me this opportunity. And also, I thank my colleague Dr. Hemendra Shah, who has given me some of these clips. And the reason is that what is holmium laser enucleation? We have always been doing before TURP or even today for a large gland we have been doing open prostatectomy. And friends, it is a duplication or a replication of enucleation is what? It is an open prostatectomy done endoscopically. So HOLEP is like performing transurethral Freyr's prostatectomy. The adenoma is enucleated, morcellated and removed, and the credit of promoting this procedure goes to Sir Peter Gilling, who has been a pioneer at doing it all over the world. He was the first man. And without wasting time, I would just switch on that how is the equipment or the armamentarium is no different from a standard TURP equipment. Now lot of innovations have come up in the armamentarium. We have got a morcelloscope. We have a Karl Storz single instrument by which you can do the enucleation and morcellation simultaneously. But we were having with us a standard Iglesias resectoscope 26 French by which we were doing TURP and the standard morcellate nephroscope. So this is enough to do a holmium laser enucleation. And the only problem in the beginning which I faced was the bouncing of the fiber. So because it's a pulsed laser, and when you have a pulsed laser, the fiber vibrates. So we had a difficulty. We sort of struggled to innovate a bridge. And now this is also an old version of this custom made bridge, but now we have a much more defined, and I am proud to say that it is a Kolkata based company which has sort of given us the bridge where we have a channel for telescope and a channel for the bridge. So the fiber is 550 micron and the channel for bridge is 600 microns, and by which we can stabilize the fiber. And I am happy to note that I was requested by a lot of my friends and colleagues to prepare a video CD, and I will request Professor Gupta to release this CD for all of you today, and this CD depicts this whole procedure. So I would love that all those who are interested in learning this procedure take a copy of this DVD, and you can just let me know if there is any problem. But this is the indigenously designed bridge by which you can stabilize the fiber and you can run around the knife. So this is how you can go all around, and I will show you that how you go all around. And these are the kind of energy settings. Energy settings, you see, with a 100-watt machine, the basic advantage is that you have a very wide spectrum of permutation and combinations. You have a permutation combination of energy ranging from 0.5 means 0.1 to say 2.5 or even up to 3 joules, 3.2 joules. That is the permutations you can have, and the rate is starting from 1 to 50. At every permutation combination there is a difference, and you can appreciate that if you want to cut, you increase the pulse rate. If you want to coagulate, you increase the energy, and for a apical dissection where you are concerned about the stress incontinence, you reduce the rate and the energy. So that is how we sort of regulate this procedure. And this is the equipment for morcellation. You can see this is a tip. You can hear 4 mm by 4 mm, and it's a mechanical cutter with suction. So with suction you can engage the tissue, and with a motor it moves to and fro, and you are able to cut 4 mm by 4 mm pieces, and this is how the morcellation goes. So in shelling out the adenoma, the laser fiber moves exactly in the same plane as surgeon's index finger. Prosthetic lobes are enucleated in their entirety, and therefore size is absolutely not a limitation, and any size of tissue can be removed. And of late, Peter Gilling described this by 3-lobe technique, and he has popularized by removing a median lobe followed by 2 lateral lobes. But I have felt that there is no need to separately enucleate the median lobe, and most of the procedure for last 5 years I am doing only by 2-lobe technique. We just make a groove at either 5, 6 or 7 o'clock, and we make a groove at 12 o'clock, join the two, and the whole prostate can be removed in just 2 lobes. Now comes the question when not to do HoLEP, which is important, and actually the only urological contraindication is acute sepsis with the counts very high, and we try to stabilize these patients. And then we have done patients with prostatic abscesses. You can do it in 2 stages. You first drain the abscess and then do it. The uncontrolled bleeding in in a very large gland, patient can't be positioned in lithotomy or unfit for regional anesthesia. And I think, as I said, that learning curve has been highlighted, and we are making, and Professor Mahesh Desai had once suggested to me that we make a model device, so that we can do experiment, and this Luminous company has come out with an experimental model, so that one can learn HoLEP. But even as we have learned the procedure, the learning curve for HoLEP is certainly shorter than that of laparoscopic procedures, TURP, and it has made really the TURP and HoLEP for those people who have managed to learn it, the operations of the past. And therefore, for learning, I must say that one must start with 40 grams, and then only one has to go further. Now comes to the question that what we have to learn is what are the tips and tricks as far as the technique is concerned, because I have been asked time and again that how easily or simply we simplify the procedure, and this is just to show you that this is the view from Viru. These are the 2 lateral lobes, and this is the view from the bladder. So these are the 3 lobes, 2 lateral and the median lobe. These are the 2 ureteric orifices. So we have to imagine in our mind a 3-dimensional picture of the prostate, and we have to keep thinking that this is a structure that we have to go all around. So as I said, that these clips are showing you the classical 5 and 7 o'clock incisions. Make the incision wide and deep till you see the capsular fibers, and the prostate tissue appears fluffy. So once you are making this incision, you can continue to go on deep and deep till you see these are the kind of transverse fibers. Once you have gone deep, you see, you can appreciate the bleeding is not there, and this depth has to be created all along the length, say from bladder neck right up to the level of verumontanum. You have to create a incision to that depth, and once you reach the capsular fibers, so you will appreciate that it becomes very easy. Many times I have been asked this problem of undermining the trigone so therefore you have to avoid this phenomena. What happens is that when you are going from Viru towards bladder neck, you can always go beneath the trigone. So this is where the complication takes place. So this has to be avoided, and how you avoid this is that once you have reached to the capsule at the level of the bladder neck, then we do this. You see here, this is the pedicle at the bladder neck, and you can see we have gone laterally. So this is the lateral cut from here to here, here to here. This can prevent undermining of the trigone, and ureteric orifices injury can also be safeguarded. And just to simplify, I have made this diagram that what happens is that when you see this is the median lobe, and prostates are never you can have nodulations, you can have vaccillations. So one has to learn that we can avoid going through the gland by staying in the correct plane of enucleation. Now how to identify this correct plane? Because if you go in this plane, you can create a perforation. If you go here and like this, you can undermine the trigone. And if you are going like this, you are going through the gland. All these three things are wrong. So what is correct is one has to go in this plane, and that is how one lifts the prostate from its base. Now, if we go further, this is how you have enucleated the median lobe, and this is how one has to create a plane from bladder neck right up to the mid fossa here, from Viru right up to this point. So this is how we always stay onto the capsule. So the crux of staying this enucleation is stay onto the capsule. And another issue is that one has to, if you have defined one area, we always move from a defined area to an undefined area. So if you are moving from a defined to undefined area, you will never make a mistake because one area has been defined clearly. So the enucleation principle is to move from a defined to an undefined area, and the problem will not be there. Now if you see, you are removing this lateral lobe, we are moving always onto the capsule. This is how we are moving on to the capsule, and this is from 12 to 9. And similarly from say 7 o'clock to 9 o'clock. So this is how we enucleate all around, staying on the capsule, moving from a defined to an undefined, and the whole lobe stays at the pedicle at say 9 o'clock. Similarly, here on this side, the whole prostate will stay with a pedicle at 3 o'clock. So the length should be approximately 3/4 of the distance between bladder, neck and Viru. Now this is with experience, one can always make complete enucleation very simplified. So 12 o'clock incision is important, and then if you see that what happens is, many a times you have enucleated from 12 to 3, you have enucleated say from 6 to 3, and the whole prostatic tissue is attached from bladder neck right up to the level of Viru. So what has to be done, that you have to move your fiber in a clockwise and anti-clockwise direction and stay on the capsule, and then the whole lobe is thrown into the prostate. The most important thing is that you avoid creation of two parallel incisions, which in turn causes confusion and disorientation, and person may be lost inside the prostate. So this is how that one should avoid getting lost in the prostate, and it is just to simplify this, that how we avoid getting lost in the prostate. You see, this is the correct plane, but what happens is that a beginner can enter inside the gland like this, or he starts and he is doing very well, but at some places he loses his patience and enters into this like this. So he creates a perforation. You can see fat here. Similarly, a person can go like this, and then he is not finding the plane, he enters the capsule like this. So these are all wrong. So therefore, what is important is that you stay in the correct plane, and one learns once he does all these things gradually. This is just to depict that this is the correct plane and this is the wrong plane. So the moment you enter a wrong plane, you have bleeding. So any conference you have seen bleeding means you have entered in a wrong plane and you create a perforation. This is the capsular plane and this is the right plane. So one has to stay in the right plane and one has to learn staying in the right plane. Similarly, you can have these most difficult area in this enucleation is this anteroapical attachment. When you have the tissue, so first thing in the enucleation you must do this, you must detach. And what I do now is, earlier we were leaving this procedure till the end, and that causes a stress incontinence. So to prevent a stress incontinence, this thing should be done first. First means you see, look at the Viru and bring the scope just at the level of the Viru, look at the sphincter and make a defined incision just 2 mm proximal to the sphincter, and then you detach this anteroapical attachment and then proceed further. So you prevent any kind of injury to the sphincter. Sometimes you face these kind of bleeders which are easily manageable. You reduce the energy, defocus the beam, work in the capsular plane, or treat the tissue around the bleeder and it goes. Similarly, you can have some kind of sometime venous bleed, and these are the ones which may not get sorted out by this. This can be sorted with laser, but this is the kind of sinus. If it gets opened up, you have to compress it with the lifted lobe, work from the other side, or one can leave it for a gentle traction. So ultimately, when we have done the procedure, you see the whole thing has been enucleated, thrown into the bladder. This is the kind of capsule you see all around. You can see some bleeders here and there. You decrease the energy, work with 20 watts, and you will find a fossa like this, where you can see the viru. This was the apical tissue around and more than 1 centimeter distal to viru, which gets enucleated like in an open prostatectomy. And if you see we will just show you, this is the sphincter. So very neatly you can see the sphincter all around, and the whole prostate has been enucleated just as if you have done it with a finger. And that is why now we are getting lot of patients with recurrent hematuриas post TURP, and when we scope them we find residual prostates, and once you have learnt the art of doing HoLEP, it is the best procedure for these cases. One has to modify the technique as per the anatomical configuration. I will just, because shortage of time, will slip this. But sometimes the other aspect of this procedure is morcellation, and as I said that we have now instruments that you do not have to change the instrument for morcellation, but there are issues about morcellation. Other issue with morcellation is this bladder biopsy. If you are not careful, bladder is compressed, you can get these kinds of bladder biopsies. One has to be very, very careful that you keep the bladder full all the time, otherwise you can take more bigger chunks or this thing. But I think I have the opportunity to train many urologists. Nobody has had any problem learning morcellation. It is one case that you learn it easily. The only thing is enucleation, but that also with a mentor training, I think 10 to 15 cases are more than enough. And sometimes the morcellation has the problem that you have nodules which are very hard and they cannot get into the suction, and therefore you need to morcellate them, crush them and re-engage them in a different location. And if the tissue is not clearly cutting, it is time to change the blade. The blade, one blade is good for 40 to 50 cases. These are the kind of nodule I am talking about. Sometimes they become cheese ball. So one has to make the surface rough, and when you can catch them by a stone punch. So all kind of methods are available, and I think the post-operative care is patient specific, and we have to respect the pre-operative status of the bladder, and accordingly we have to keep the catheter. But in majority of the cases one can take out the catheter within 36 hours or 24 hours. So friends, I conclude here by stating that it is an excellent procedure when once mastered. The technique is quite straightforward. Outcomes are superior to other transurethral approaches, and less invasiveness of the procedure makes it desirable over open surgery in large glands. Learning curve should not be a discouragement, but should be viewed as mastering any endoscopic or laparoscopic procedure. Lumenis has recognized our center for mentorship and training for Southeast Asia. We have trained urologists from all neighboring countries, and even Libya, USA, the people have come to us for learning. Preceptorship is essential to avoid some of the pitfalls, or at least learn how to negotiate them once encountered, and we at RG Stone find the procedure enjoyable and superior to any other method of prostate reduction. Thank you.